Okay. Hi everybody. I'm sorry for the delay. The last class finished late, so we had to wait a little bit. Okay, if you can hear me, I would like to say hello to everybody and good evening. And I hope you're having a very good time. Hope you're not very tired. Hope you're not very hungry. And I hope we will have a great class today. If it's possible, I would like it very much if you could all share your webcams or at least share your voice with me. I would like for you to open your microphones, open your webcams so that we can all see each other and think that we are sitting together. Could you please do that? I would appreciate it too much. Okay. First of all, I want to say that, as you all know, English is not my original language, and maybe that's the case too. So if there is anything that you don't understand, even a sentence or a word, do not hesitate to ask me to repeat. And I'm not still seeing anybody here or hearing anybody. If we have participants here, I would like for you just to introduce yourselves and tell me your nationality, maybe. That will help us a lot. We can get to know each other better. Can anybody introduce himself or herself while I try to share a screen? Hello. I'm not hearing anything, so I think you're not there, okay?
Hello.
Hi.
Hi. Sorry, I'm not going to switch on my video cam, but I'm Fahima. I'm from Malaysia.
Fahima from
Glad to be
Malaysia.
here.
Nice to meet you. When have you come to Iran? When you come to Iran?
2017.
2017. Okay, it's very nice to see you here, Fahima. Thank you.
Thank you, too.
Okay. Anybody else? I myself, I'm Kousar, Asna Ashari. I'm a new professor at Children's Medical Center. And, well, I'm Iranian. Okay, anybody else want to share his or her story with us? I'm going to start anyway, but I will wait for a few seconds because I would like very much to hear from you guys. Well, Iranian ones are welcome to here to speak. Okay. Okay. I will start then. Let me see the chat.
Hello.
Hi.
Hi, I'm Fatima Qambari. I'm an Iranian student. Yeah, that's it. I don't have anything else to say.
You're our stager?
Yes.
Okay, great. It's great to have you here, Fatima. Thank you.
It's great to be here.
Okay. So if you're not going to speak, I will continue, but whenever you like to speak or ask a question, just feel free to, and just turn on your microphones, okay? We have 15 participants here. I hope we will have more soon. We will be recording this session, so for the ones that cannot attend today's class, we will just share the recording with them. Okay. Let me check the chat. Okay. Today we're going to talk about acutely ill child assessment and resuscitation. I will wait. I am screen sharing. Can everybody see the screen? Okay.
Yep, totally.
Okay. Okay. Acutely ill child assessment and resuscitation. I'm sorry, I think there's a problem with the connection. I will reconnect. Okay, I think this lecture is a problem, so I'm gonna just talk in this way. Part 1, assessment. Approach to the emergency evaluation of a child. It includes 4 steps. The first step is general assessment, then primary assessment, secondary assessment, and tertiary assessment. I will explain about each step here. The first step is initial assessment. In initial assessment, you need to assess tissue perfusion and oxygenation, okay? You only have a few seconds to do that. It means that in a few seconds, you should only observe the child and you're not supposed to touch the child. You should check for airway, breathing, and circulation, for which I will explain soon. We'll have something in the chat, sorry. Okay. I've been asked to click on full screen, but I am afraid I will have a problem after that. Okay. No, we're okay. Okay. First of all, the first task that anybody should do whenever he or she is faced with an injured child or an injured person, the injured child or injured person is a person you find in a bad condition. For example, the child is lying on the ground unconscious, okay? The first task that you should do is to verify scene safety. It is very important to make sure that the scene is safe, that, for example, there's no fire, there is no earthquake, and you are safe. And if not, you should just escape from that situation. And if you can, you should take the child with you. But if not, nobody will blame you if you escape from the scene. Okay, just first of all, you should make sure to be safe. General assessment includes a few very important steps. Okay, the first step is to say, are you okay? When you're faced with a child that's lying on the ground, that is in a bad condition, that is in distress, you will have to tap him on the shoulder or just call him and say, are you okay, honey? Are you okay, baby? Are you okay? And if the child answers, if he says, for example, no, I'm in pain, no, I have a problem, you know, something like that, you will make sure that, well, the child is conscious, but he shows hands. So you go through the rest of your survey. You will go through primary assessment, secondary assessment, and tertiary assessment. But if not, if the child is unconscious and he cannot answer you, then you should shout for help. You should shout, somebody please help me, help, or something like that. And if someone comes to you and say, what can I do for you? You should say, call the ambulance and ask for an AED. AED, automated external defibrillator, as you can see in this picture here. We will talk about this later, but it's a device for applying shock to a person who is in cardiac arrest, okay? So you will just call for an ambulance with AED. And then you should yourself begin the BLS, or basic life support algorithm. Okay, the CPR. I'm not going to talk about CPR right here. If you have time, we will talk about it after assessment. And if not, we will talk about it in the next session, okay? I'm going to talk about the patient who has answered you and who has answered, no, I'm not okay, I'm in pain. And then you're sure that you can go for primary assessments, okay? Okay, primary assessment includes, as you can see, 5 alphabets: A for airway, B for breathing, C for circulation, D for disability, and E for exposure. Primary assessment is where you use hands-on assessment, is where you touch the child. It's not like initial assessment that you just observe the child in a few seconds. You know what the difference is? In initial assessment, you took a look at the child, okay, and you saw that the patient is not well. How did you understand that the patient is not well? Through A and B and C, okay? Through airway, for example, you saw that the patient's maybe the jaw is dislocated, or in a bad position, he cannot breathe, okay? And you understood that the breathing is not well. I'm gonna explain about breathing. Or you understood that circulation is not well, but only a few seconds, okay? And then after that, you judged, you understood that you should call for help, or call for ambulance, or you should go for primary assessment. But what you do in primary assessment is a little more complicated, and I will explain about it here, okay? In primary assessment, you will do a limited physical examination. You can check for vital signs with whatever you have in hands, okay? You're in a scene, you're faced with a child on the ground, for example, when you were walking in the park. You cannot find any blood pressure cuffs, okay? But you can take the temperature by touching the child. You can understand if he is cold, or if he is warm, or if he is really hot, he's feverish. You can understand if the heart rate is low, or the patient is tachycardic, okay? Whatever you can do. Or for the ones that are very prepared and they carry this oximetry, they can take the saturation of the child too. As you can see here, the first step is airway, okay? I have put a picture here of the collar. The collar is a device that we use to fixate the patient's spine, or fixate the patient's neck. It's for the injured child, the child that we think that maybe a trauma was inserted to him, okay? So it's very important to know that all this talks about airway. A very important thing to do is to fixate the child's neck. After fixating the neck and making sure that you are not moving the child too hard, you're not injuring the child through his neck or his spine, you will pay attention to the airway. The airway should be patent and maintainable. It's very important. Patent is the airway that is open, that you can just be sure that the patient is breathing through well, okay? Maintainable is an airway that will be patent in a very short time. For example, there is fluid inside the mouth of the baby, but you can just make the problem go away with suctioning, okay? Or there is a bulge in, for example, a piece of bread inside the mouth of the baby, and you can just dislocate it, you can just extract it with one move of the hand, okay? So that's maintainable. Or, for example, this child may be in respiratory distress, for which I will explain, but here, with inserting an airway inside the mouth of the child, we have made the airway maintainable. We have made sure that the child's airway is open. Why did that person do this? Maybe because the person is not completely conscious, okay? So you're afraid the airway will be compromised very soon, so you will put the airway inside the mouth of the child. Here I have written something important here, okay? Your book says that the most common precipitating factor for cardiac events in children is respiratory insufficiency. While when you find an adult in a bad condition, for example, a guy who has fallen onto the ground, the first thing that comes to your mind is that the person has had an MI, okay, a myocardial attack. But for a child, that's not the first hypothesis. You think that he has had a respiratory insufficiency problem with respiratory system. So the things that you should do should concern, first of all, the airway and the breathing, and then circulation, okay? Well, this is basically the same in adults too, but it's very important to pay special attention in children to airway and breathing. Now look at this child. This child is in distress, okay? He's very anxious. He has nostrils that are flared. Can anybody here tell me what other problems you can find in this child? I will be very glad to hear from you. Can you say how we can say that the child is in respiratory distress? A good student, please. We're waiting. Just tell me the signs that you see. If you're not comfortable speaking, you can type too. Okay, great. It is Zahra, I think. She means subcostal retraction. Okay. Mohammad Nazir, he says tachypnea. Okay, great. Right. Okay. You should observe the child from up to bottom. Okay. You will observe the nostrils. The nostrils are flared. It means that they are widened. Okay. It is very, very important in the neonates. No. Only by this we can understand that the neonate is not feeling well. Okay. Subcostal retraction, yeah, but upward, if you this part, it's suprasternal retraction. Okay. In the suprasternal part, it's just retracted. Yeah, we have grunting here. Yeah, right. I will share a video of grunting with you. Muscle retraction for intercostal and SCM. Yes, that's right. After suprasternal retraction, we can observe intercostal retraction here between the ribs, and then subcostal retraction. Okay. So I'm gonna share some videos with you here. What I have here. Okay. Guys, do you see the video? Please type or say something. No? Can. Okay. I think there's a problem with sharing the video. Okay, I found it. You can see the video now, I bet. Right? Can you see the picture here? Oh, I talk. Okay, I'm sorry. I don't know what the problem is, but I've shared it. So you can't see anything here. No? Still no? Okay, so there's a problem here. We will continue, and at the end of the session, I will try to show you the pictures. And the videos. It should be here, isn't it here? Okay. Okay, did you see this baby? Can you tell me what the sound was that he was making and what was the sign that you saw in the patient? That's great. Yeah, grunting could be heard. That's right. Akefe. Yeah, Shakiba. The patient is having difficulty breathing, so he has grunting, and he also has subcostal retraction, if you pay attention. Yeah. Okay, so these are very important. The patient appears as if he's going to be gasping and he's going to just stop to breathe. Okay, stop breathing. I will show another one if I'm lucky. Okay. That's one too. Tell me what the sign is. What was the sign? Anyway, what was the sign? This is supraesternal retraction. The video says tracheal tug. It's also called tracheal tug, but oh my God, so there is a problem with the internet. I'm so sorry, guys. Okay, let's get back to our slides, and then if you're lucky, we can have the screen share afterwards. Okay. After this one, I hope you can see the slides now. We have the picture of this child. He is having difficulty breathing too. His abdomen is descending while the lower sternum retracts. Okay, it's a seesaw effect, but your book calls it paradoxical chest motion. Okay. So this is very important. When you look at the child and you see that his sternum or his coastal area is retracting, but his abdomen is distending. Okay, you may see this in neonates, that it might be normal in neonates, but it's abnormal in older children. Yeah, of course, Zahra, we will share it in the group. I will send it. Okay. The other things that you should pay attention to in a child with respiratory distress is the air movement. You should pay attention to the chest expansion, to the breath bounce. If you have the stethoscope, it's very good to auscultate with the stethoscope. But if you're in a scenery, in a park, for example, you cannot use the stethoscope. Some of the breath sounds are audible without the stethoscope too. For example, wheezing, stirred, or even grunting or things like that can be easily heard without a stethoscope. You're welcome. Okay. About circulation. Circulation is very important. By observing the child, you can understand a lot about his perfusion, about his condition. Mottling is a sign of bad perfusion, for example, okay? You will see the picture of mottling here. I bet many have seen it in MACSB because we have many septic patients, many hypovolemic patients, and septic and hypovolemic patients may show this sign. You can see the reticular pattern here of vascularity. It means that this child does not have a good condition. Maybe you have a child with diarrhea and you think that, okay, this patient has diarrhea and I will just provide the fluids necessary for diarrhea. But if you see this sign, it means that the condition is catastrophic and you should just attend to the problem very quickly, okay? The other sign is pallor. Pallor is when the child is pale. It may show that he is hypovolemic, he is anemic, okay? Temperature is important. You might not have the thermometer, but you can touch the child. When the distal parts are cold, it means that the child has a problem in the circulation, okay? So you should provide fluid or vasoactives that we are going to talk about. And if the child is feverish, when it says that the child is septic, for example. Capillary refill, it's very important. Can anybody tell me what is the normal capillary refill of a child or of an adult? Capillary refill, right, Ali Noruzi says 2 to 3 seconds. 1.7 seconds, less than 2 seconds, right. All of these are right, yeah, we say in general 2 seconds, right. You push the bed nail, and then you wait. When you just release it, you wait for the circulation to get back. If it takes more than 2 seconds, it means that the capillary refill is delayed, and it shows a delayed perfusion. And this child also might be hypervolemic. Okay. After skin perfusion, we get to peripheral and central pulses. Central pulses are very important when you're with a child that needs immediate attention. For example, the child that I told you about that was unresponsive when I shook him and I asked him if he was okay. The first thing that I should have done was to check for central pulses, because I want to make sure if there is any heartbeat, if there is any work from the heart that I can observe, okay? So I will check for central pulses. But when I'm sure that we have central pulses, that the patient, for example, is awake, is talking, a patient that is talking, of course, his heart is working, okay? But I want to make sure if the heart work is adequate. So I will check the distal pulses to make sure that the perfusion is okay. Central pulses of a child can be found in these areas. When you're checking the pulses of an infant, because the infant usually has a big neck, a fatty neck, checking for carotid pulses is difficult. So we check for femoral pulses, for example, or brachial pulses. But when the child is older, you can search also for carotid pulses. Okay. But in distal parts, well, you have more options. You have the option of checking for radial pulse. Okay. Tell me the normal pulse of a, for example, 2-year-old child. Do you know what the normal pulse rate of a 2-year-old child is? I'm asking because this is a difficult question, okay? And many students don't know the normal range for pulse rate of children, okay? I will share a table with you. Less than 40. Less than 40 is very low, okay? Less than 60, okay, per minute is the limits or the cutoff that will make us very nervous. If the pulse rate is less than 60, we should do CPR. Okay, it's very low. So the lower margin is 60 in all the children. Okay, but we have normal heart. This session is available. Yeah. Okay. Thank you, Dr. Zeri. Yeah, the normal range for each age is different. I will share the normal range, but I wanted to just point this out that 60 is a very low heart rate, okay? And different ranges are for different child ages available, okay? Also, the volume and strength of the pulses are very important. For example, if you have bounding pulses, it means that the patient is, for example, septic, or he might have a cardiogenic problem. But if you have weak pulses, right, Zahra, yeah, it's for respiratory. If he has weak pulses, it means that the perfusion is delayed and the perfusion has problems, okay? Okay, this is Matalink again. Well, heart rate, it's, well, I explained about it before. Tachycardia and bradycardia are important. And tachycardia is the earliest and most reliable sign of shock. If a child comes to you with tachycardia, you might think that, well, tachycardia is okay. He has fevers. He is a little dehydrated, but it might be a sign of shock. You should pay special attention to this patient. And bradycardia is very bad. As I told you, bradycardia can show that you should start immediate CPR. Okay. Blood pressure in children, it's not as important as adults. I'm saying it because we have many patients in the adult ERs coming with a main problem of high blood pressure. This problem is much less seen in children. But about low blood pressure, well, this is very important to be paid attention to, because patients in shock just represent with low blood pressure, okay? But this is a late finding. And fall, you see tachycardia, you see delayed capillary fill, you see even the consciousness that is a little lowered, the patient is a little sleepy, the urine volume is lowered. We will talk about dehydration later. But I want you to know that blood pressure changes very late in children, later than other findings, okay? After A and B and C, we reach disability. It's a child's neurologic function. A child's neurologic function can be checked through response to light, standard scores of neurologic function, ABPU, GCS, and 4. I will explain about ABPU and GCS. 4 is for traumatic patients. It's a little different, but basically similar with GCS. And well, we will go for ABPU first. ABPU is a very easy way for communication between physicians. When you say the patient's level of consciousness is A, it means that the patient is or you just inserting some painful stimuli to the child. My monitor says that my internet connection is unstable. Can you still see me? Okay. V means the patient responds. Thank you, Shakiba and Mohammed Nazir. V means the patient answers to verbal stimuli. Okay, it means that the patient will not spontaneously open his eyes and start talking to you. You should call him to just draw his attention. Okay. And P means the patient answers to painful stimuli. When you call him, does not answer. But when you insert a painful stimuli, he will answer. He will open his eyes. He will make a sound, something like that. And U means that the patient is unresponsive. He will not answer to any of these stimuli. And about GCS. Can anybody tell me what the difference is between the GCS interpretation of a child and an adult? Can you tell me why should GCS be different in children and in adults? In what part? I will be very glad to hear from you instead of typing, but if you want, you can just type. Yes, right. The verbal response, Fatemeh, Jahanhara. They don't understand sentences, right? Because of verbal part, right? That's right. Well, so the eye and the motor sections are similar in children and in adults, but the verbal part is different because they cannot speak and they cannot understand the speech of others, okay? Okay, the eye section includes 4 parts. The first part is nil, gets the score of 1. It means that the patient does not answer to any stimuli and will not open his eye under any condition. If he only opens his eyes, if you insert pain, the score is 2. If he answers to speech, the score is 3. And if he opens his eyes spontaneously, the score is 4. Zahra says verbal response depends on the age. Yes, it depends on the age. And about the motor section, there are 6 sorts here. If the patient does not show any motor response, it's nil, it's none, and it's 1, okay? And remember that the least score in each section of GCS is 1, it's not 0, okay? If the patient shows extensor response and he flexes his upper limbs, the score is 1. If he shows abnormal flexion in his upper limbs, the score is 2. And pay attention to this part, that the flexion and extension refers to upper limb, okay? And if the patient withdraws his limbs or himself when you insert pain, when that score is 4, okay? It's important when you, for example, pinch the nipple of an unconscious child, if he tries to just push you back, if he tries to hit you, the score is 5, he's localizing, okay? But if he withdraws, he pulls back his arm, he pulls back himself, it gets a score of 4. And if he obeys, for example, we tell him to show 2 fingers, well, that's the score of 6. as one of our good students has said, there might be differences in these two things too. For example, if you call a 6 months old and say, for example, honey, wake up, he might not understand, he might not open his eyes. In these two sections too, you should pay attention to the ability of the child to understand you. For example, if you tell a 1-year-old to show 2 fingers, he cannot show 2 fingers, okay? It doesn't mean that he cannot obey. Just say something that he can understand, okay? That's why ABPU is useful in children, because it is not dependent on the age of the child. But verbal response is completely dependent on the age of the child, because the less than 2-year-olds cannot speak at all, okay? So, excuse me. So verbal response is completely different. For children, this is the table that we refer to that I have put here. Infant and young child verbal response. If he does not have any verbal response, the score is 1. If the child is restless and agitated means that the child is always crying, is always agitated, okay? The score is 2. If he's persistently irritable means that when you touch the child, he will cry, he will scream. When you speak to the child, he will cry and scream. But it doesn't mean that he is always agitated. When he is triggered, he will be irritable and agitated. The score 4 is for consolable crying. The patient cries from time to time, but is consolable, okay? He will be okay if you try to soothe him. And the score 5 is for the child that smiles and fixes and follows and maybe speaks. Okay, it's different with adults and older children. As you can see, the patient that can speak is differently. Excuse me, I have a problem here. Okay, it's okay. Is differently analyzed, okay? If civil sounds, it means that you cannot understand what he says at all. He has some moans, he has something that he is trying to say, but he cannot say. That's the score 2. If he uses words, but the words are inappropriate, the score is 3. If he is confused and the conversation is confused, he's not oriented to time and to place, the score is 4. And if he's completely oriented, the score is 5. Are we clear here with the differences? Okay. Exposure. You only go through exposure if you are sure about A, airway, B, breathing, and C. If you have maintained all of these, if you're sure that the patient is okay on A and B and C, then you can do exposure. You can just undress the child and check for burns, bruises, bleeding, joint laxity, and fractures. Okay. Now we're done with the hard part, with the primary assessment, and we have reached secondary assessment. Secondary assessment is when you take a focused history. A focused history should be taken by sample, okay? S stands for signs and symptoms, A for allergies, M for last oral intake, and E for events leading to illness. You might have heard of sample in surgery bar because we use it a lot there. When you're checking the history, you should ask for a sample from the parents, okay? And here you can do a focused physical exam. You can do the physical exam according to the complaints of the child or the parents. And tertiary assessment is when you reach the hospital. In the hospital, you have access to the laboratory examinations. You should check for blood chemistry profile, CBC, liver function, coagulation studies, and ABG. And the imaging, you should check for chest X-ray. Chest X-ray provides a very good image of heart and lung, okay? For example, in this image that I have shared in the PowerPoint, you can see a typical image of a child with a history of trauma. Can anybody tell me what the problem is with this chest X-ray? Kiana says pneumothorax. Sahra says pneumothorax. You're very smart students. Yes, it's a pneumothorax, Shakiba. Thank you, and Ranga. Yes, thank you. As you can see, the right lung is hyperinflated, and it has caused a shift in mediastinum to the left side. It is very commonly seen in children with trauma, and adults with trauma as well. Insert a needle, and you should aspirate if you're in the thank you, Akif. If you're in the ER and you do not have access to chest tube, and you see this picture, you should insert the needle. Afterwards, when you are stabilized, when you are just moving the patient to a more to an ER with better facilities, you can use the chest tube. Okay. Yes, great. Okay, we are done with assessments. I think it's late and it's near start time, and I'm sorry again for the delay with which we will explain about the CPR in the next session, because it needs concentration and it needs your participation, because it's practical. Okay. Now I will answer any questions about the assessment, if you have any, and then I will see you in the next session with resuscitation. Is there any question? I think it was very short and easy, but it was good for a start. You're welcome, dear. You're welcome. You're welcome. For the next session, I would like to hear from you, and I would like you to talk, and I would like to see you, so be prepared, okay? And we can just see some movies together and do some practical work about CPR. Okay, you're welcome. And I will share the videos with you in your groups. I will. I promise. Okay, we say in Farsi, khasta nabashi. It means don't be tired. It's a little ridiculous, but it's very common. Okay, goodbye, everybody. Nice to see you. You're welcome. You're welcome.